Hello and welcome back to our second event tonight, live event. This time it is our IVF webinar as it is 8 p.m. UK time. I'm happy to be back and thank you all for joining us already. Please let me know that you can hear me as always. And Dr. Maria, hi, how are you? Hope you can hear me as well.
Hi, Caroline. How are you? Good to be here with you tonight as usual.
Exactly. This is not our first webinar. I am happy to be able to do another one with you. It's always a pleasure. So welcome back. You are definitely our frequent presenter. So we always are glad that you are able to join us and do it for us and with us, of course, for our patients. And let me just remind everyone that all those events has been brought to you with a huge help with our ambassadors and partners. You can see all of them right here on the screen. There are too many of them to simply name one by one. However, I'm sure some of them you already know as we had previous webinars with them as well. And we also need to thank our top experts. There are plenty of them. One of them is also Dr. Maria. As I mentioned, she had some webinars with us already, and I'm sure we will have more. So again, thanks to those experts and Dr. Maria as well. And also, well, I need to just remind you that Dr. Maria Arque is from Fertility International Clinic, and she is actually medical director at Fertility International. And this Fertility International is located, of course, in Barcelona, in Spain. So she will discuss today a very interesting and important topic on fertility preservation, and she will be able to tell you all that you need and should know about that. She will start with her presentation that will take approximately 25-30 minutes, and after that we will go straight to your questions. You simply need to put those questions in the chat section so that Dr. Maria can answer them for you one by one. So don't hesitate, go ahead and type this in. And I'm sure Dr. Maria will be able to help you out a bit and answer all of your questions. And well, I guess that is it from me. Dr. Maria, are you simply ready to begin with your presentation?
Yeah, I'm ready, Caroline. Thanks for the kind introduction.
Perfect.
So, yeah, as Caroline said, I will be speaking about fertility preservation and a little bit what all the things that I think that are important to know whenever you are about to start a fertility preservation treatment or either you're considering it. As Caroline said, I am Dr. Maria Arque. I'm the medical director at Fertility International. And what I'm going to be discussing today, it's going to be focused on the fertility physiology for you guys to understand why we should be considering to undergo fertility preservation. Also, when should we be doing it? How can we do all the process? And then I tried to focus also on all the most frequently asked questions from most of my patients to see if that way things are as clear as possible for you. Okay, so first of all, I would like you to explain you a little bit of physiology about how the cycle works and why is the reason that we should be considering freezing our eggs. So basically, we all women have an important limitation, which is that we are born with all the eggs that we have, and we will not keep on producing new eggs during our whole life. So both quality and quantity of the eggs decreases with time and age. Okay. Usually, the moment in our lives in which we've got more eggs is when we're around 7 months old and we're still in our mom's bellies. And by the moment that we are born, there are around 1 million eggs left in our ovaries. And by the moment in which we reach puberty, there's around 500,000 eggs in the ovaries. Every month, what happens is that from all the eggs that we have in the ovaries, there is a pool of those eggs that it's pre-recruited, okay, and that have the potential to grow. But obviously, we are not animals that are capable of having more than one kid or maybe two kids at the same time. So the body has to naturally select just one egg to grow each month. What happens is that at the very beginning of the month, okay, at the very beginning of the cycle or the period, the FSH, that is the follicular stimulating hormone, it's going to increase a little bit, okay? the follicular stimulating hormone is going to make that from all those follicles that can grow, which each follicle contains one egg, that there just one that is selected, the one that has more receptors for the FSH. Okay, all the other ones are going to be discarded. This egg that has been pre-selected, this follicle, is going to start growing, and while it's growing, it's going to start to produce another hormone that it's called estrogen, that it's also going to rise. The estrogen is going to be responsible for preparing the endometrium, okay, which is the lining of the uterus that will start to get prepared for an embryo to implant. Then, around the moment in which this follicle is mature, that we can expect that the egg that is inside is mature, there's going to be signs sent to our brain because the estrogen levels are going to rise a lot. There's going to be an LH surge, and then that's going to trigger ovulation, which means that the egg is going to go from the ovary inside the fallopian tube. Okay. What happens then is that if we're lucky, and when this egg has gone from the ovary inside the fallopian tube, it's fertilized, then this embryo is going to start developing, and it's going to go back to the uterus until it implants, and at the stage of blastocyst, more or less 5 years after the fertilization, and then we will have a pregnancy. Okay. So what I wanted to mainly make you understand with this is that every month we lose a lot of eggs regardless of what we do. There's just one that's going to be selected for being the one that can lead us to have a pregnancy, but all the other ones are being lost anyway. Okay. So yeah, trying to summarize all this idea, this is an estimation model that Wallace and Kelsey have done, which are a couple of scientists that were saying that obviously the decline of the quality and quantity of the eggs is very important with age, and it looks like there is an important inflection point when we reach the age of 35. And this is also a graphic to show that most of our eggs, when we are 25, are going to be good quality, but as we age, some of those are not going to be good quality, and both quality and quantity declines. In this graphic, what we can see is how with age our likelihood of achieving a pregnancy decreases, which is that continuous line that we see, that decline here at 34, 35, and afterwards that increase on the risk of miscarriage because of that alteration in the quality of the eggs. This is also to summarize the likelihood that we can have aneuploidies on the embryos if we reach a pregnancy with age. And as you can see, the risk of Down syndrome increases a lot with age, and the same for the rest of chromosomical abnormalities. So after explaining a little bit about the physiology, that I hope that it was clear and that you understood, why should we be freezing our eggs? So the reality is that our patterns in the way that we reproduce have changed a lot because of several different reasons. And the reality is that we're tending to postpone motherhood in general because of work commitments, because we want to build our career, maybe because we have not found the partner with whom we want to have children, maybe because we don't have the economic resources to have a child, and also because when we are young, we are told very well how to avoid getting pregnant, and we are taught about contraception, but no one warns us or sends us the message that our fertility can decline a lot with time, and it declines before what we expect. Now, one of the things as well is that our 30s are our 40s are the new 30s and all those things, which means that we don't have this sense of getting old for having babies. And unfortunately, even though we might not feel 40 or 30, and we might not look 40 or 30, our eggs are 40 or 30, and then the quality keeps on declining.
Hello, Dr. Maria?
So what would be the... I'm here. You hear me, Caroline?
Yes, okay, sorry.
Hello?
For a minute. For a minute I didn't, but it's okay. Sorry. It's okay. Go ahead.
Perfect. No worries. Okay, so what would be the advantages of egg freezing? So first of all, having chances of achieving a pregnancy at an age in which it would be more difficult to achieve a pregnancy naturally. It gives us women reproductive options in the sense of having a little bit more autonomy as well to decide when we want to achieve a pregnancy, when it's the right time for motherhood for us. And also, when we speak about the reproductive options, it's just to decide if we want to be solo moms, if we want to just wait a little bit of time to have children, or either um, just go ahead and have children right as soon as we can. The other thing is that we women tend to sacrifice a lot in our lives for children. And this was a survey in which they were comparing the reasons why men were looking for a part-time job and why women were looking for a part-time job. And if you look at the data, you see that in men, 43% of the cases when they were looking for a part-time job, it was because they could not find a full-time job. And in women, that 42% accounted for looking after children or incapacitated adults, which means that obviously a lot of times we find ourselves in a moment in which we need to make some sort of very difficult decisions. And it looks like we should prioritize or either our career or either our motherhood. And egg freezing can give us the chance of maybe not having to choose in between one thing or the other, just choosing the right time for us.
Hello, Dr. Maria.
Hi, I'm here, but I don't know why the light is getting. I don't know, maybe if there is any problem with the connection because the light is not charging now.
Okay,
Sorry for that. And
it's okay.
yeah, in that slide, I just wanted to show which are the trends right now. It looks like the trend is that fertility preservation for what we call social reasons, that it's just postponing maternity or motherhood, it's growing a lot. That means that we are starting to educate better people about that. And it has grown over 16% in the last 3 years. Most of the cycles that we're doing for fertility preservation are because of social reasons now. Okay. And obviously, in the past, we have been doing this mostly for patients who were about to face some kind of treatments because of medical reasons that would have a detrimental effect on their likelihood of achieving a pregnancy after in the future, like oncologic patients or patients who were about to have surgeries, endometriosis, and things like this. So the numbers are going up, and also this is a technique that it's getting more technified, and the results are much better. When we look at the distribution in the age of patients when they are about to do the egg freezing, we see that there is a percentage of patients who are coming when they are between 31 and 35, but most of our patients are coming when they are 36, 39. I will get back to this idea later, but it looks like we're sending the message too late in time, right? Because the ideal time to freeze eggs is before we are 35 to avoid this decline on egg quality and quantity. So if we want to maximize the likelihood of afterwards having a child and be as cost efficient as possible with undergoing a process like egg freezing, we should be doing that before. The other thing that is interesting as well is that we see that the more educated people are, more tendency they have to freeze their eggs, probably for these different reasons. First of all, education is power, and when patients are educated, they have more choices. And second thing is because most likely people who are more educated tend to postpone more motherhood because they have other commitments before in life, and they might be prioritizing their careers for some years. This is a survey that was done in gynecologists in the US, and just to see how they were seeing the topic of fertility preservation and if they were informing their patients about that. So 83% of those gynecologists thought that fertility preservation should be discussed in the annual gynecological review with patients, but only 27% of them were doing that between the age of 18 and 35, and 76% of them were doing that when patients were between 35 and 44. And when we were asking them why they were not doing it, 72% of the cases they were not doing that because they were lacking time, and 41% because of lack of knowledge. So again, that's the main thing that we should try to change as gynecologists, as fertility specialists, that it's to try to spread the awareness of the fact that we should be doing all this much earlier. Again, I mean, I'm insisting a lot in the same ideas, but I think that it's super important for everyone to understand why. Why ideally before 35? Here in this slide, we have a couple of summaries of data. The first one is from Kobo, which is probably one of the persons who has investigated the most egg freezing and the results. And if we see the likelihood of having a child or a live birth, depending on age per every egg that we retrieve, it decreases dramatically with age. When we are younger than 35, our likelihood per egg to have a child it's 6.6%, and after 40 years of age, it's less than 2%. So it decreases a lot. And in the other side, we see one of the group of Santiago Muné, which is also someone who has investigated a lot about the quality of embryos and the embryos with chromosomical abnormalities. And we see that regardless of the number of embryos that we have, what is most important in terms of how many embryos we have that do not have chromosomical abnormalities is age. As you see, with egg donors and with the most of the embryos are going to be chromosomically normal, like 61%. In women who are all younger than 35, 48%, and at 42 or later than 42, it's going to be only the 11%. This is again data from that study that I was explaining from Ana Cobo, in which we're seeing that the older we get, the less number of eggs we can collect, and less of those are eggs that we can freeze, because not only it's a matter of how many eggs we're collecting when we're doing the process, but also a matter of if those eggs are mature and we can use them to freeze them for future use. And here we have the data about also the clinical pregnancy rate, okay, and the survival rate of the eggs after warming them. When we have when we froze the eggs, we have to thaw them afterwards to use them for undergoing IVF or ICSI. And the survival rate is also dependent on age. So when we're younger than patients who were younger than 29, there was a survival rate of 94, 95%. And when patients were older than 40, it was around 85%. And the clinical pregnancy rates also were declining with age. I have to say that generally speaking, nowadays, with the techniques that we use and with all the technification of the vitrification, which is the technique that we use to freeze eggs right now, survival rates of eggs usually after the thawing process are generally around 95% in general. And this slide is from the same study that looks at clinical live birth rates, depending on the number of eggs collected when we are younger than 35 or we are older than 35. And as you see, the likelihood of having a live birth, it's directly dependent on the number of eggs that we've been able to collect and the age of the patient. So it looks like this cutoff at 35 is very clear. And here it's a little bit the same idea. In this graphic, what we see is which is the likelihood of having one child two children or three children, depending on the number of eggs that we have collected. And it comes to the same idea that I was explaining before, that the more number of eggs that we have frozen at a younger age, the better chances of having good guarantees of most likely having children with those eggs. So the conclusion of this part of the presentation could be that the survival rate of the oocytes once we've vitrified and then we thaw them, it's greater than 95% in women who are younger than 35, but in women who are over 40, it drops up to 85%. In general, the pregnancy rate that can be expected in a patient with less than 11 eggs vitrified, it's around 40%, and it can increase up to 60 if there are 12 or more eggs, and it's close to 90% if the woman has around 20 eggs and is younger than 35, 36 when she's doing the egg freezing. The expectation of live birth per vitrified oocyte is between 4 and 8% in patients younger than 36. And therefore, it is a technique that in general we would not be recommending to do for patients who are over 37. And with low ovarian reserve, I would like to point a little bit this idea. Obviously, if you're a patient who have low ovarian reserve and you are younger than 35 and you are not ready to have children yet because of whatever reason, there is the option of doing something that is called egg banking, in which we can do several cycles and accumulate those eggs to use them in the future. Obviously, it's going to be economically more expensive, and it's going to be more you're gonna end up more exhausted after doing several stimulations, but this is an option to try to maximize your chances in the future. It's a matter of discussing that with the patient in detail and making sure that the patient is aware of what she can expect out of this. So how do we do the fertility preservation? So just going back to the history of fertility preservation very quickly. First birth of a baby with vitrified eggs was in Australia in 1986. And since 2012, the American Society for Reproductive Medicine has declared that egg freezing is no longer an experimental technique. It is already considered an advanced technique, and it's established. And it has many indications, and it is a solution to the ethical or moral situations of embryo freezing and the concerns of afterwards maybe not using those embryos. So how we do that? In the past, we were using what we call slow freezing. Okay, what happened with that? We didn't have the technology of the vitrification. That with the slow freezing, what happened is that there were crystals that were forming and inside the oocytes, and that was damaging the quality of the oocytes. That's the reason why in the past the results with the eggs that were frozen were not as good as they are nowadays. Okay, now what we do is the vitrification, that it's like a super fast freezing, and we're in less than 1 second we're decreasing a lot of the temperature of those eggs. Okay, reducing the damage of the intracellular structures, and also in terms of the survival and pregnancy rates are much higher than with the slow freezing. Okay, that's a little bit the same idea, that comparing the data between the survival rate and also the fertilization rate when we're using vitrification or slow freezing. The data is very consistent and clear that we should be doing vitrification. And for any of you guys that is considering to undergo a fertility preservation or egg freezing, one of the most important recommendations that I would like to give you all today is that you should look for a center where they do vitrification. That's like something mandatory nowadays. All the top fertility centers everywhere and in the world are right now using vitrification. So what are the steps involved in doing the fertility preservation? So first step would be to do some diagnostics and planning with your doctor. Okay, the test that they are going to ask you for can vary a little bit depending on the clinic, but I will go through that a little bit later. And then you have to undergo the ovarian stimulation. How does that work, the ovarian stimulation? So basically, you will get your period. Usually around 3 days after you started your period, you will have to start taking injections. What are those injections? Basically, FSH, the same hormone that I was explaining at the beginning that helps the follicles grow. During the time that you're taking this medication, you will have to come for some bloods and scans because we need to monitorize how your ovaries are responding to the treatment. Typically, you will start injections, and 5 days after, you will come for first scan. We're gonna do bloods and and the scan. Then 2 days after, you will have to come back for the same, and 2 days after, the same. Usually, around 10, 12 days after you started the injections, most of the follicles will have grown enough to make sure that the eggs that are inside are mature, and then we're gonna trigger the final maturation of the eggs and the ovulation, and then we're gonna organize the egg collection. Okay. The egg collection is a small procedure that in most places it's done under conscious sedation. And what we do is with the same transvaginal ultrasound that we do when we're just assessing with vaginal scans, we go inside the ovaries and we collect the eggs. Then at the same time, what will happen is that the biologist in the lab is going to assess those eggs. It's going to check which of those are mature and are good to be frozen, and they are going to freeze them. And the ones that are not good are going to be discarded. Okay. And then there is the fifth step that it's the possibly coming back later in the future if you want to use those eggs to basically do an IVF or ICSI cycle and have a baby with the eggs. So I'm going to try to go through the most frequently asked questions, as I was saying. So first of all, it's which are the tests that you will have to do. As I was saying, that depends on the center where you do the test, but most likely everywhere they're going to ask you for some tests to assess your ovarian reserve, that it's going to be assessed with your age, your AMH, and a transvaginal scan to check what is your antral follicular count. The AMH is a blood test, okay? It's a hormone that it's produced by the small cells, the granulosa cells that are surrounding the eggs, and helps us to have an idea about how many eggs are in the ovaries. And the antral follicular count also gives us complementary information to know which is the ovarian reserve. And with your age, AMH, the antral follicular count, and your BMI, we can calculate which is the dose of medication that most likely you will need to have the best possible response to the ovarian stimulation. Then we're going to do a full blood count and coagulation because obviously we're going to do an egg collection, and we want to make sure that there are no coagulation problems. We're going to do vitals. You know that under European legislation, we have to do vitals for all patients who want to undergo any kind of fertility treatment. Currently, we're doing also COVID-19 tests previous. The karyotype would not be mandatory to be done, but as we are going to probably use those eggs in the future, I would recommend to do the karyotype. The karyotype is our map of chromosomes. We all women and we all men as well, we have 23 pairs of chromosomes. The difference is that in the sexual pair of chromosomes, men have an X and a Y, and we have two X's. And sometimes, even though we don't have any kind of medical problem, we might be carriers of some small changes in the chromosomes in the karyotype that, even though they are not affecting us, if we were about to have a child, this could increase the chances of having a baby with chromosomical abnormalities. And I think that it's an important and useful information to have before. And also we will check the thyroid. So coming to the question of how many eggs should I freeze, I would like to point out and insist a lot in the fact that even though we freeze the eggs, that's not a 100% guarantee that we're gonna be able to have babies with those eggs. I wish it was, but the idea is that we would like to try to maximize the chances that you're going to have at least one baby. So therefore, our objective would be that we freeze between 16 and 20 eggs before the age of 35. Okay. When we have an AMH that it's more than 2.5 nanograms, we would be expecting that with a mild stimulation, we would be collecting around 15, 20 eggs. And with an AMH that it's lower, we would expect to be collecting around 8 or 10 eggs. That can differ according to a lot of other parameters. That's very general, but that's for you guys to have an idea. And then the other thing that I wanted to point out is the idea of the egg freezing funnel. Okay, so basically we go through a stimulation and we end up collecting 15 mature eggs. And of those 15 mature eggs, when we freeze them, and then when we warm them, around 90% of them survive. So let's say that we have 13. And of those 13, there are 10 that fertilize. And of those that fertilize, they arrive at the stage of being embryos uh, 5. And then when we do the PGT, the pre-implantational genetic testing to see if the embryos are chromosomically normal, we see that there's only one embryo that it's normal. So and that could be a pretty normal outcome, okay? So as I'm saying, a lot of times when we're doing IVF, it's kind of a natural selection process that it's happening in the lab. And unfortunately, we humans as a species, we are very subfertile, and it takes a good number of eggs to end up having one baby. What are the risks of the process? Because that's something that I get asked a lot as well. So the risk of the treatment itself would be one of the risks. There is, in the past, there was the risk of hyperstimulation ovarian syndrome, that it's a complication after undergoing the treatment with all the drugs that we give for ovarian stimulation. Nowadays, with the protocols that we are using and with all the drugs that we have available, I'd say that OHSS is a complication that practically it's not existent anymore. And in all the clinics that they work properly, that should be like practically an OHSS free clinic, okay? And then the risk of the egg collection, that obviously as any surgery, it has some risks. There's risk of bleeding, but it would happen in less than 1% of cases, and most of the times if there's a small bleeding, it stops spontaneously. There is no need for doing anything. There's a small risk of infection. That's the reason why we usually give prophylactic antibiotics when we're doing the egg collection. There's a small risk of damaging the bowel or the bladder with a needle, the surrounding structures, but it's extremely unlikely. I think that it's less than 0.7%, 0.5 in general, so extremely low. And then the risks with the anesthesia, that if you're generally healthy, you had anesthesia before, or you don't have any medical problems, should not be a concern. Then it is true that there is something that we should not forget, is that biologically speaking, the ideal would be that we were having babies earlier in life, but socially, a lot of times that's not possible. But it is true that with age, the obstetric risks with pregnancy increase. What I'm trying to say here is that obviously, if we get your eggs when you're young, we can freeze your eggs and use them in the future. But in the future, when you get pregnant and maybe you are 40, there is higher risk of having complications during the pregnancy, and also perinatal complications like preeclampsia, like high blood pressure during pregnancy, gestational diabetes, or preterm delivery. Okay. And then the socioeconomic risks that the age at which some women decide to become mothers, thanks to vitrification, and might end up having negative economical consequences for the future generations as well. The other thing that I get asked, is there higher risk of obstetric and perinatal complications with pregnancy with frozen eggs? No. So it's not because of the fact that we're using frozen eggs, because when we compare fresh or frozen eggs, there is no higher risk of complication. The higher risk of complications might come from the fact that we are older at the time that we're getting pregnant, not because we're using frozen eggs. And thus, the egg freezing increases the risk of breast cancer. And I have a lot of patients who are very concerned about this as well. So this is a study that was published at JAMA, which is one of the most that's a review that it's a reference worldwide, and they've made that study in 25,000 women. They followed them up for 21 years, and they saw that those patients were having exactly the same risk as general population to develop breast cancer. So far, there's no data to say that we have higher risk of breast cancer when we do egg freezing. And what are the most common side effects of the process? So most likely, a lot of the times, the medication, it's going to make you have symptoms that are similar to PMS. Okay, so you might feel a little bit more bloated, tired, you might feel breast tenderness, and you might feel mood swings. Most women do normal life during the whole process. Maybe they are exercising a little bit less, but in general they can keep on doing absolutely normal life. And most of them refer to feel completely normal once they have the period that usually, with the medication that we use nowadays, you will be having your period around 1 week after the egg collection. The other question is, for how long can I have my eggs frozen and do they deteriorate with time? So, for how long you can have your eggs frozen, that depends on each country. Okay, the legislation can be different. In Spain, you can keep your eggs frozen up to the age in which you can legally do a fertility treatment, which is up to the age of 50 years old. Okay, and getting to the point, if the eggs deteriorate with time, so there was a study done by Cobo as well, in which they analyzed 42,000 egg donors, and they saw that there were no difference in fertilization rate, clinical pregnancy rate, neither ongoing pregnancy rate, when they were using the eggs that were frozen during less than 6 months or over 5 years of storage. So there were no differences with that. And then the longest period of storage resulting in a live birth for now, it's 14 years. So it was recently, I don't recall right now exactly the time, but I think it was 1 or 2 years ago that a baby was born with eggs that were frozen 14 years ago. So it was with slow freezing as well. So that's reassuring. And what can I do with my frozen eggs if I don't want to use them? Okay, so again, legislation can differ in every country. In Spain, the possible uses of the eggs are, or either to keep them frozen in storage in the case that you wanted to use them for in the future. You can donate them to another woman if you fulfill all the same criteria as egg donors. So you must be younger than 35 when you have done your egg freezing. And also, the other thing is that obviously you cannot have any infectious disease, neither any genetic diseases. And then in that case, you could donate it to other women. You can donate them for scientific purposes, and also you can opt for discarding them if you don't want to use them for any of the other uses explained before. So the take-home messages from today is that oocyte vitrification is an effective and safe technique, that education is essential at all levels. So it is super important that all gynecologists, general practitioners, and fertility specialists, that we all educate patients and especially young women about how our fertility declines with age, and that we have the option to make the decision of freezing our eggs earlier in our lives when it would be the best moment to do it. Women who opt for, live birth rate mainly depends, when we're using frozen eggs, mainly depends on the age at the time that we're doing the oocyte vitrification and the number of vitrified oocytes. And women who opt for preservation should vitrify the eggs at younger ages to increase the chances of having a biological child. And the goal of our doctors is to continue to raise awareness of the risks of pregnancy at older ages. And I think that's everything I wanted to share with you guys today. I hope that everything was clear. I am more than happy to address any questions that you might have right now. So Caroline, I don't know if you wanna take over.
Thank you. Perfect. Thank you so much, Dr. Maria, again for a wonderful presentation. Lots of useful information, and well, this kind of topic definitely, as you have said, as you have shown us, that this is kind of topic that you should be more frequently discussed. I think because many women are simply not aware yet that it's actually there are options, there are definitely options. We are waiting for some questions, so let me remind everyone to simply type in all of those questions and Dr. Maria can help you out. But in the meantime, if I may ask, first of all, if you have seen that recent increase that when it comes to this kind of egg freezing method. So have you seen that women are more and more often decide to actually go for it?
Yeah, absolutely. Because there are two couple of things. I mean, as I explained during the presentation, we we haven't been freezing eggs for that long. It's been in 2012 that the ASRM has declared that not an experimental technique anymore. It's just 8 years ago. So there is kind of a gap or a generation of women who are now struggling with fertility that did not have neither the information, neither the chances that we're having, and neither the options that we're having right now to freeze their eggs with all those I can't say warranties or certainties, but with a very good chance of having a child in the future with their own eggs. And I think that the awareness is arising. I think the message is being spread much more, and that's the main reason why egg freezing is increasing a lot. I am so
Excellent.
happy to see that every day I get more and more patients who are coming to freeze their eggs at younger ages, because that makes me realize and feel like we're changing a little bit
Yes.
the situation, and that hopefully in the next few years, uh, when we present the slides, we will be able to say that most of the women who are coming to freeze their eggs are women who are younger than 35.
Yes, excellent. Thank you so much. This is important because, as I mentioned, I think that it's still not spread still enough. Yes, the woman I've heard. It's very interesting. I've heard that some some people actually, some doctors are mentioning that it would be good if actually the first that gynecologist appointment, it would be possible to simply let the women know, yes, that there are possibilities, so they could think about it way ahead before they can actually they will start thinking about the families. Thank you so much, Dr. Maria, for that. And I would like you to show you the question right here. And there is the question about, could you please go over the AFC test again?
Yeah, yeah, Sheena, thanks for the question. So the AFC accounts for antral follicular count. So when we're doing a transvaginal scan, what we can count is how many follicles do we have, okay? As I explained before, the follicles are the ones that are containing the eggs. And when we're doing that test, that we usually try to do it once you just got your period, which is the best moment in which we can do the antral follicular count, that gives us an idea about how many eggs more or less can we expect that are going to grow with one cycle of stimulation, and gives us complementary information to the AMH, which is the blood test that we use for also assessing your ovarian reserve.
All right, perfect. Thank you so much again for answering this question and clarifying that. And well, it's about this is a comment about what you have already said. So I really like your view of gynecologists educating their patients at an earlier age. This really needs to happen. Couldn't agree more,
Yeah.
right?
I mean, yeah, I mean, the same way that we speak, that they speak about contraception, they should be speaking about egg freezing and fertility.
Exactly. Perfect. Thank you so much. And actually, there is another comment right here. A wonderful and concise presentation. I love that. I'm also happy that the increased awareness of social egg freezing. And yes, again, we couldn't agree more. Okay. And
Thank you so much for the comment. Thanks. And I hope that we keep on spreading the message. I'll do my best, everything I can to keep on spreading that message.
exactly. And I think that, this kind of webinars also are a good option to actually spread the word, right? So hopefully
Mhm.
we will be able to reach like more and more women. And thanks to that, it will possibly be easier for them as well in the future, right? When they will be starting
Mhm.
planning the families. We are still waiting for some questions. So let me remind everyone that if you would like to ask anything at all and, get some advice, go ahead and type in your question. I have one more in the meantime,
Yeah.
because I this definitely receive this quite often. So you have mentioned, of course, that it's best to freeze your eggs before you are 35. But what
Mm-hmm.
would you say if, for example, you have a patient that is around 40? Is it still do good to do it, or what would be your advice?
Mm. That's a very good question because I face that situation a lot of times in the consultation.
Exactly. I thought
Yeah,
so.
I mean, it really depends on which is her personal situation. And for example, if it's a patient that already has a partner, I explain her that obviously what the main thing is that when we're freezing the eggs, we will know how many of those are mature, but we will not know how many of those are chromosomically normal and are going to lead to have a blastocyst and a live birth until we don't use them for doing an IVF cycle. So sometimes I think that when we're doing a freezing at later stages in life, it could give us like a false sense of reassurance because, oh, okay, I have my eggs frozen there. Yeah, but we know that most of those eggs are not going to be good quality. So at that stage, I usually try more to see if there is if the patient wants to get pregnant as soon as possible, maybe probably to go through a treatment that can get her pregnant before, and obviously probably do pre-implantational genetic testing to see if the embryos are normal or not. And if she still knowing which is the likelihood of having eggs that are good quality, um, and being absolutely aware of all the pros and cons of undergoing the process, she still wants to do it. Obviously, I cannot, I am not there to judge or to decide for her. So as long as it's not going against her health, I would then agree to do it. But it would also depend on the ovarian reserve. It could be very different if we have a woman that has an AMH of 4 or 5, and you expect that with just one cycle you're gonna get 20 eggs or 25. Even if she's 40, probably um, some of those eggs are going to be good. So maybe it's more worth it. But if we're facing someone who is 40 and has an AMH of zero point 0.2, and you expect that maybe you're going to collect a couple of eggs each time, I would not at all encourage egg banking or undergoing egg freezing in a patient like this, if that makes sense.
Of course, perfect sense, definitely. So thank you so much again for that, because as I mentioned, this is a very frequent question, and many women over 40 are still wondering whether to go ahead with it or not. And of course, they definitely want to be reassured. Okay, I am just waiting if we have any other questions. If not, we will be finishing. But already, I would like to thank Dr. Maria for tonight, for joining us again. This is not your first webinar, and it's always a pleasure to be able to do it with you. And well, I know we are having another webinar pretty soon. So this is, I believe, 22nd of June. So I am very happy to be able to do it again.
Yeah.
And yes, there are some comments right here. Everyone is,
Yeah, next webinar is about a completely different topic, which is the IVF add-ons. And
yes.
usually a topic that there's a lot of controversy about it. And yeah, we'll see. So far, this is the webinar in which we had less questions, Caroline.
Yes, that is true. But there is one right here, so let's go ahead with it. Is there any way at all to test for chromosomal issue before freezing, or is it just not advised?
And that's a very good question, Sheena. So there is not a test to check for chromosomical issues of the oocytes. I mean, not that it's spread or used. We can do that when we're freezing embryos, because at the end of the day, that's what accounts or what's important. So what we can do is before freezing, before deciding which are the embryos that are worth being transferred, once we have fertilized those eggs with sperm and we have them at the stage of blastocyst, we can do a biopsy of those embryos, and we can just do the karyotype and see which of those are worth being transferred and completely chromosomically normal. But no, currently there's not a test to check directly which eggs are chromosomically normal. That would be great because that would be a way to have a clear idea of the realistic chances of those eggs being worth being used in the future. Regardless of that, I just want to point out as well that even though the egg is mature and it's chromosomically normal, that's not a guarantee 100% that you're going to get a blastocyst and you're going to get a healthy pregnancy with the egg.
All right, perfect. Thank you so much for that. Someone is typing, so I want to make sure that we will answer all the question. And recently, I also have heard that if it's like the best age to freeze your eggs, I mean, is it even possible to be able to find the best age for that?
Mm-hmm. Wow, that's a very tricky question, Caroline. But
True.
I can't answer. It's a tricky one. Okay, so if we're looking at the best quality of the eggs, obviously your eggs are going to be better at 25 than when you are 30 or 35, correct? Or when you're, yeah. Usually we don't recommend to freeze your eggs when you are very very young. We're seeing that, for example, women who are 18 or 19, we've seen that a lot with egg donors who are maybe 18 or 19, super young. There's some kind still of eggs that are not mature, that the process of egg maturation is not exactly the best sometimes, not always, but sometimes. So I would not consider egg freezing unless you're doing that for oncologic purposes or because you have a medical issue. Having said that, I'd say that obviously your eggs are going to be in a better quality at 22 than at 30. But when you're 22, you still have a lot of time to think about what, when you want to have children and what are your options. So I think that probably that's something for debate, but probably what I would recommend is that from a very early age, since you start going to the gynecologist, that usually it's when you start having sexual intercourse or when you are 18 and you start having pap smears and regular checkups. I think that's something that should be checked. It's the ovarian reserve, because
All right.
I think that if we know what is our ovarian reserve, at least we can warn patients and say, hey, if you are not planning to have babies soon, most likely in the future you might struggle. So maybe in your case we should be doing fertility preservation. Obviously, all women who have already some infertility issues or some gynecological problems like endometriosis, like PCOS, a lot of different problems, I think that they should have a chat with their gynecologist or with a fertility specialist, even at when they are young, to assess all the options and how those pathologies can affect their fertility in the future.
Yes, definitely. This is definitely interesting, and I couldn't agree more. I hear more and more that actually this has to AMH should be checked, quite earlier, and that many women will be able to simply perhaps avoid, complications, and also they still would be able to use their frozen eggs rather than go for straight away, for example, for egg donation, right?
Yeah.
So definitely. Thank you so much for that as well. And the next question is right here. So thank you for your presentation. How many psychostimulation do you recommend and how often?
Hi, Lorena. Thanks for the question. I'd say that, as I pointed out before, our goal would be to get around 16, 20 eggs frozen, okay, in total. So obviously before you're 35, ideally. In the terms of how often can we do the cycles, probably I would do stimulation one cycle after the other, unless you're feeling unwell, because we're seeing that we're having exactly the same results. We can even stimulate during luteal phase and do something that it's called dual stim, and we can do one cycle of stimulation after the other without having to lose more time, which is something that sometimes for some patients is more convenient. We can spread out a little bit more, but I'd say that the number of cycles that leads us to have at least between 15, 20 eggs frozen.
Okay, perfect. Thank you once again for answering this question. Someone is typing, so I definitely want to make sure that. Okay, here it is. There's another question right here. Let me show you. I am a 50-year-old currently using a donor, 30 years old, that had 3 boys already. Number of blastocysts shall I expect, and what number shall I expect, and what could possibly lead to lower blastocyst possibility? What number of blastocysts shall I expect then?
Hi, Viso. I'd say that first of all, even though for a lot of time we thought that male age was not that important when we were about to do fertility treatments, we have currently more data saying that sperm quality also declines with age. There is a more important decline after the age of 40, and there is a slightly higher risk of having chromosomal abnormalities on the embryos after 40. So this is something that we have to account for, even though you had 3 boys before, and I assume that they are healthy. So that's reassuring as well. Regarding the egg donor and the number of blastocysts to expect, it will mainly depend on how many mature eggs are guaranteed from the center where you're doing the treatment. Okay, usually there is a minimum number of mature eggs guaranteed. Usually, if you're getting around 8 eggs from the donor, you should be expecting to have at least 2 blastocysts, more or less. Sometimes there might be donors that we don't know why we end up having poorer results. And yeah, but I'd say that a minimum of 2 blastocysts should be the normal thing.
Okay, thank you once again for answering that question and for your questions, of course, too. And this is like the final call for those questions. So if you have any left, go ahead and type them in. If not, we will be finishing for tonight. But yeah, there are more thank yous coming. Yeah, right here. So I just want you to take a look as well. And it seems that we will be finishing for tonight. So, Dr. Maria, it's always a pleasure. Thank you for joining. And is there anything else you would like to add?
Yeah, I think that I've tried to be as clear as possible with my message, but yeah, I mean, for me, the final message is that if you're younger than 35, you are not looking to have children soon. Uh, I would really strongly recommend to go see a fertility specialist, check your ovarian reserve, and discuss the option of egg freezing, and really consider that, because that gives you the opportunity of being your own egg donor in the future. And that's something that, as I said before, a lot of women of an older generation could not do. And I think that this is something that we have to take advantage of, and just go for it if we can.
Yes, exactly. I mean, this is very, very important message to take home for sure. And again, thank you so much. And let me just remind everyone that this has been recorded. So within the next few days, you will have a chance to watch this on our website, mayavfences.com. And also, you can share it with any younger women in your families or friends. And perhaps, we should definitely spread the word. There are possibilities nowadays. And also, let me remind that if you just simply subscribe to our YouTube channel, you will be notified when the new video is uploaded. So this is very easy to do, and in that case, you will be able to simply watch it whenever you want to and need it. Plus, you can also follow us on our Facebook page and Instagram, and that way you will be updated when the new event is on. And well, thank you for tonight. Thank you, Dr. Maria, again for joining our initiative. It's well, till the next time. That's all I can say, because we know we do have more of those webinars coming. Thank you all for coming to us as well. Hope to see you tomorrow as well. Thank you and good night.
Bye, Caroline. Thanks for everything. Thank you for
Thank
all the
you.
audience for listening. Bye-bye. Bye.
Thank you. Bye.